Good afternoon, everyone, and welcome to the next webinar in the Impacting Policy series brought to you by the Institute for Health Policy Studies. Our topic today is collaborating with community-based organizations and coalitions for policy change. And it's my honor to have four you. And then after those presentations, we're going to have a conversation among the five of us. And then for about the last 15 minutes or so of the hour, we're going to open it up to you to ask your questions. So the Q&A forum is open. You are welcome to put questions in the forum as you think of them, and we will take them in the order received. For those of you who may be wondering, we are recording this session and the recording will be available on the IHPS website at some point, probably a week or so after this webinar. So without further ado, I would like to turn it over to Jane and Mara for their presentation, and I'm going to get their slides up so that you can see them. So take it away, Mara and Jane.
Terrific. Thank you so much. I'm going to get started and hope that Jane will jump in with everything that I'm forgetting. I just wanted to give an example of two different projects that UCSF and Fresno EOC have been working on over the past several years. But before I do that, actually, Jane, would you a little bit about Fresno EOC and just kind of the range of programming they offer, as well as the clinic that services provided?
Yes, my name is Jane Thomas. I am the Director of Health Services with Fresno Economic Opportunities Commission. We're based here in Fresno County. Fresno EOC has about 40 different programs, social services programs and health programs within the county. The Community Health Center is focused on our general practice and family planning, reproductive health, and that's how we get connected with Dr. Decker. One of our projects with the state of California, California Personal Responsibility and Education Program, the UCSF team was the evaluation team for that project, and we built that relationship. And moving forward, we're partners with all these projects, wonderful projects with UCSF.
Thank you. I just wanted to start with that because I want to stress how fortunate UCSF is to have somebody with the depth and reach of Fresno EOC. They are trusted partners throughout Fresno County, and we couldn't do the work without them. One of the projects that we co-designed with Fresno EOC, we called In the Know. This was a youth-based, co-designed sexual health education program with wraparound technology. So we were the evaluators or the researchers, and Fresno EOC was the implementers. They implemented at over 50 different sites. This was a 5-year RCT, so we had over 1,200 youth that were randomized to participate. And again, I want to stress that we started this from the beginning, from the grant application in conjunction with Fresno EOC. They really helped to think of where we could implement what would be useful. They know the youth and they know the communities. And again, not only did we collaborate with EOC, but we co-designed it with youth representing the community. A couple of the quick pictures here. On the upper right is part of the design process, this user-centered design. On the lower left, this was us presenting our results in Thailand last November. So this was in the International Family Planning Conference, and it's something that we strongly believe in, that not only are we presenting, but and sharing the results back to the community, but that we're actually co-presenting and co-sharing our experiences. Next slide, please. So based on that, we then had the opportunity for another 3-year grant to develop what we call the Rural Education and Development Project, also known as READY. So this, in addition to our collaboration with Fresno EOC, is with Fresno Superintendent of Schools. And we're working with youth in rural communities in California, in Fresno, using this systems thinking approach. So again, the fact that Fresno had the connections, knew the places where we could be implementing an after-school programs and foster care, all sorts of different places was crucial to the success of this program. I'd also love to stress that we started this program in July 2020. So we were not able to meet in person. This was in the worst part of COVID. But thanks to Fresno and our ongoing collaboration, we were able to make a success of that. This piece also incorporated youth as co-researchers. So the folks in the lower right were our mystery clients. They called clinics and pharmacies to ask them about services. And then in the bottom left, these were our parents that participated in a series of parent workshops. They were the ones who told us what they wanted to hear, and EOC worked to develop that. Based on this, we just received another 5-year grant to expand the READY project, and again, bringing all of EOC's expertise to reach more youth, reach more parents, and really listen to what the previous collaborators had suggested for improvements. Jane, did you want to add anything?
Yes, I just wanted to share how valuable this partnership is with UCSF. We have the inside information and the involvement with the community, but with the data and the evaluation and the assessment, the focus groups that we've formed, UCSF's commitment with the project makes it so much easier to work and understand what our actual teams in the community need, especially in the rural areas. It also helps us get funding to go towards Fresno County. This data information, along with our successful stories, we share with our policymakers in the school districts that we're constantly attending board meetings, presenting our projects and what it does for our teams in this county. We go to the state, all the way up to Washington, D.C., present all this data and stories to help with our growth and to provide more resources for our teams here in Fresno. It's an awesome partnership, and we would not have done, none of this would be possible without without UCSF's expertise in those evaluations. We love working with Dr. Mara and her team.
Okay, well, thank you very much, Mara and Jane. I'm going to turn it over to Kim and Z now to present about their partnership.
All right, I think Z is on her phone and maybe we'll be able to turn on her camera. Awesome. Okay, great. So just to start off, what we wanted to kind of call what we're talking about today really is this concept of inside-outside collaborations. And our focus here is to improve cancer disparities in Alameda County. So can you go to the next slide? So first, we just wanted to give you a sense of kind of the background that our work is embedded in, and that's really focused around the development of Umoja Health, which, next slide, thanks, the mission of which is to build coalitions that increase community capacity to achieve health equity. And we do that through 3 things: information and communication, direct health services delivery, which sometimes involves data collection and what might be lightly called implementation science, and then workforce development. And then I want to ask Z to share about the mission of the Public Health Commission.
Good afternoon, all. I apologize for my technical difficulty. My name is Jeanette Harper. You can call me Z. I am currently a commissioner for District 4 of Alameda County, and I'm also the chair of the Health Equity and All Policy Subcommittee for the Public Health Commission. In addition to that, I have served as chair of the Public Health Commission once and vice chair of the Public Health Commission twice. The mission of our Public Health Commission is to review and assess emerging health needs, initiate and improve health and disease prevention and policies. And we do that by engaging with our partners and informing our directly to the Board of Supervisors of Alameda County, in addition to serving as an advisory to the Public Health Department. The public health, the County of Alameda is comprised of, I believe, 14 incorporated cities, 6 unincorporated cities and rural areas, and that our county covers approximately 821 square miles. And that goes from Oakland all the way to Livermore. Alameda County, our last count, is home to approximately 1.6 million people. So the opportunity for the Public Health Commission to provide a lot of information, knowledge, and leverage to community partners is really astounding to a certain extent. I mean, to think that we can help to impact 1.6 million people in regards to really bringing attention to issues of health, prevention, disease, policy making is a huge thing for us. So primarily, we really advocate for the health needs and public policies and programs, as public health isn't clinical. So we're primarily involved in the educational and advocacy and policymaking pieces of it. So part of what we do, we work with HICSA, Healthcare Services Agency, and again, as part of the Public Health Department structure, in addition to the Board of Supervisors. Our health equity and our Oakland, the District 4 that I represent and the city I represent, is the largest of the 14 incorporated areas and unincorporated areas of Alameda County. According to our latest information, we have 422,994 residents within Oakland alone. That is down a bit from the 439,341 that we had during the 2020 census. The cities range from Oakland to Piedmont. And again, Oakland is the largest. And District 4 actually has probably one of the more diverse districts throughout Alameda County, as it does incorporate the incorporated area and the unincorporated areas, which are primarily Black and Brown. And the highest level of disparities across the board are contained primarily within that district. So again, we have an opportunity to really try to mitigate and diminish those disparities as they exist. So the purpose of the Health Equity and All Policies Subcommittee is to really, what we're focusing on is really developing a lens, a kaleidoscope of sorts that really sees and addresses health and racial disparities where they exist. So at this particular time, we are developing tools of racial equity and health equity. And that's primarily the work we have been doing this last, I would say, close to a year after COVID, because COVID enlightened so many people as to the depth of social determinants of health and the issues of inequity in healthcare and racism in healthcare. So we're taking this as an opportune moment to really try to come up with strategies to again mitigate those effects.
Great. So that just sets thank you, Z, that sets the stage for, how this collaboration has moved toward what we're now seeing is a change in policy within the Public Health Department. So can you go to the next slide? And I think the thing that is important about what we're doing and how we've gotten here is really the history. And Claire Brindis used this term with me some years ago. She called it the history of now. And she said, you always need to be asking, like, what is the history of this moment? How did we get to where we are? So I'm going to start at the end. So if you could just advance the slide and just say that, the question is, how did we get Alameda County to, as a public health department, to incorporate a cancer control initiative into their priorities and agenda when there are no public health departments in the greater Bay, the 9 counties of the greater Bay Area that have a specific cancer control focus. And it is, as Zia pointed out, partly because they are not clinical in nature. And so it's daunting to take on something that would have clinical implications. So can you advance the slide? I just wanted to point out that this really all started, more than 20 years ago with the development of our community advisory board in the Cancer Center. And I want to just give a hat tip to Rena Pasick, who started the community advisory board before community advisory boards were popular, before they were kind of a thing. But once the pandemic started in 2020, our CAB, even though they're supposed to be focused on cancer and we're supposed to focus on cancer with them, asked us to address the pandemic. And that is just one example of what we call our year-round non-transactional community engagement. We're engaged with the community that has no idea about the divisions within our institution. And so when they're thinking about health and UCSF, they're thinking that we do all of it. So when they asked us to do the COVID work, go ahead to the next animation. We adapted what we have been doing in San Francisco under the United in Health initiatives that happened both in the Mission and then in Bayview, took it over to Alameda County and adapted it adapted it into what the community decided to call Umoja Health. And so that last slide that you just saw is is all of the different community partners who are involved in Umoja Health. And effectively, I want to point out that Umoja means unity in Swahili, and it refers to the oneness. And that oneness is really reflective of this idea that we're all on the same mission, even though each of the partners that you saw on that slide actually provide a different kind of service in their usual daily work. But once the pandemic rolled around, the question was, how do we bring all of those services together to move toward equity in how resources were being distributed and in outcomes in COVID? So we basically pulled together all the credible messengers, the people who had already developed trust and had relationships in community to bring together weekly meetings. Next slide. And also to deliver pop-up events. And I highlighted along this pathway where Z and I have had the opportunity to collaborate, because you start to see Z pop up very early in this effort in the pandemic, really working on COVID initially as a volunteer, collecting data on the front lines of those that we were testing. And at some point in the fall of 2020, we released the results back to the community. That's always first, of what we learned about how people were feeling about engaging with us versus engaging with traditional brick and mortar healthcare delivery systems. And based on what we learned, which we were all surprised by, that folks were, and particularly African-American and Black folks, were willing to engage with us around hypothetical trials if we were to bring them out in the future. And so we were all shocked by that, including the public health department, which then gave us our own allocation of vaccine when it was released in 2020. I do go ahead and click another animation. I do want to point out that you see Z popping up all over. So after she started volunteering with Umoja, we embedded her as a community advisor for the Wisdom Study, which is a national breast cancer study trying to develop precision screening approaches, and particularly for women of color for whom there are no risk predictor, polygenic risk scores, partly because there's not enough data. And then as we started getting into delivering vaccines, it became very clear that, well, if we can deliver these kinds of services and information, we could also be delivering cancer information, cancer control information. And Z's role as a breast cancer navigator and Alameda Health System meant that this was close to her heart. So as soon as we brought out cancer information, Z was one of the first to come out with us and deliver this information directly to the community. And so now I'm going to turn it over to Z to kind of talk about how, being embedded in Wisdom and being embedded with us delivering cancer information moved her next strategic activities with the Public Health Commission.
Thank you, Dr. Rhodes. Well, having a bird's eye view of Umoja, and just as important as the delivery of services, the philosophy of Umoja was very enlightening for me as a public health commissioner, because we are tasked with community engagement, involvement, and being able to really deliver educational materials and health related, don't want to say empowerment, but health related empowerment, for lack of a better word, to community. And I was beyond impressed with the reception that Umoja would always get consistently from the communities that is most impacted. So what I did was I brought that information back to our public health department and saying that, there is a need for cancer information to be disseminated within the community just as much as COVID. And this also spoke to our health equity in all policies mission, part of our commitment. COVID had just taken over everything, so you could barely get a word in edgewise. But I saw the effectiveness of presenting all that material at one time. So we began having those conversations within public health, how to further embed support of cancer educational materials, and working more so with Umoja to help us in crafting and delivering that message. So in October, we started having meetings with the director of our public health department and trying to figure out.
Sorry, advance this. Go ahead and advance the animation.
Oh, I'm sorry.
That's okay.
We began, speaking with our director and deputy director of public health department to find out how and where we could embed this very important work. One of the first major steps that we took into really bringing cancer into the public health sphere was in October of 2022, when we held our very first breast cancer awareness presentation from the public health department, the Public Health Commission. There had never been one prior to that. And it was with Dr. Rhodes' facilitation and her introduction to nationally recognized figures that really was the catalyst and the change for us being further embedded now. Our panel in October consisted of Dr. Laura Esserman, May McCarmo, the CEO of Tiger Lily. We had the local representative from American Cancer Society, and Ricky Fairley, who is nationally renowned too as a clinical trials proponent, advocate, and expert. After that presentation, which was moderated by Dr. Rhodes, first of all, we went 30 minutes over our allotted time. We went from 6 to 8:30. That has never happened in public health history of staying 30 minutes beyond a meeting. But the overwhelming interest and support allowed us to actually make cancer care one of our 5 priorities in our strategic plan of January 2023. So it had an immediate impact. Cancer education and cancer community support is now an established priority of the Public Health Commission. It was very slow moving, mostly because of COVID, but because there isn't a lot of understanding around where cancer would fit in the public health department structure, it was very slow going. After that presentation, we have been moving now with greater speed and complete support of our public health department's leadership. So we started that out. That was the first big thing in October of 2022. March 25th, 2023, we established cancer care as one of our 5 priority areas in our strategic plan, in the Public Health Commission strategic plan. In June, we adopted a equity framework. Central to that framework discussion is the approach of Umoja and the way in which equity is actually being built as the foundation of that work. So Dr. Rhodes, she was our inaugural guest for what we are now calling our Health Equity Through Empowerment series by the Public Health Commission. And she has been on the agenda 4 times since January, and she just did her presentation on September 26th of 2023 as our inaugural presentation began, and it was on Health Equity Requires Action. And it has been so popular that we've had to put her up as an encore performance just because so many people are actually gravitating toward it. And I think besides equitability, there's a respectability, and there's a gratitude for being seen by cancer patients because they don't fit anywhere other than their doctor's appointment. And this makes them feel a part of a community of caring as opposed to just a cancer community. And that has gone a long way in helping us to earn more cachet as a trusted messenger, because now they can trust that their message is not only being heard, but it's being centered. And that wasn't possible prior to us partnering with Umoja.
Thank you, everyone. Happy to take any questions.
So thank you, everyone. Thank you, Kim and Z, Jane and Mara. I think what we're going to do next is have sort of a roundtable conversation with the four of you. I remind our participants, if you have questions, please put them in the Q&A forum, and we will take them after we have the robin roundtable conversation. And with the conversation, Z and Jane, I really want to start with you because I want our audience to really hear from you as community partners who are very engaged with UCSF. And so Z and Jane, my first question, if you could talk a bit more, expand on how partnering with Kim and Mara respectively benefited the organizations with which you work and the people that you serve. So, I mean, Jane, would you like to start, and Z, then your thoughts?
Yes, the great partnership of UCSF and Fresno ESC, we would say that it's the evaluation, the expertise that Dr. Decker and the community gives us important distinctive area that our agency does not have the capacity for. The information and the specifics of our surveys and analysis assessments of our community, that information allows us to design and co-design projects that are very specific to meet the needs of the areas that we are wanted to provide resources, education, and especially health services. Our clinic, which is a family planning reproductive health, working in an area, Fresno County is a very conservative area. Going into the city officials, the county officials, the school boards and districts, not knowing and understanding what topics are on sex ed, those pose a huge challenge for us to convince them that this program, this projects that we have for you will benefit the students and the teens within our county. Because of this partnership, we were able to convince some of the policymakers and change some of the existing policies within our school districts. So now our EOC Health Services created this teen transport system so we can provide confidential services. And the school is allowing us to pick up the teens from the school to go into our clinic and receive medical services and family planning and reproductive health. The parents also sometimes are coming to us. It is confidential, they're not supposed to know, but some parents knew about our project, would personally call us and say, hey, my child needs help. Can you pick up my child from school and take them to your clinic? So it has a lot of positive impact. And we used to be, back then when we were partners with Dr. Decker in the beginning, Fresno County is one of the country's top to the highest poverty level in the country, and the high teen birth rates, and top 5 on the STI infections like chlamydia, gonorrhea, and syphilis. So with our relationships with UCSF, who has helped us identify some of this, we were able to bring some resources into the community and allowed us to service them more. And now our clinic, we love the kids that are able to come. The board of supervisors in different school districts are allowing us to do this the administrators, the principals, and the teachers. We provide sex ed education at the schools, traditional schools, and charter schools. And this has allowed us to extend those most needed confidential services, especially to our teens. So we truly appreciate that, and thank you, Dr. Decker, for getting us involved. And your team, they are very much involved and committed to the projects that we have here at Fresno County. Not just within EOC, but for the entire community, our parents out in the rural areas, the administrators, the schools, they've met with Dr. Decker and her team met with the city mayors of the rural communities to address and ask, doing the assessment of what their needs are. And this has been a tremendous help. It's all plus positive for us. Thank you.
Thanks, Jane. Z?
Well, what I would say is that our partnership with Umoja has really elevated the presence, the and it is educating both the public health commission and the public health department. Cancer care and the need for cancer to be elevated and embedded within the public health department structure is a need, and that need is now being addressed. But it's also a better representation of whole person care, because working with Umoja, we feel as though we're closer to providing care and resources that are representative of not only individual health, but community health. Because we can have cancer care and cancer information sitting next to Mpox, sitting next to COVID, sitting next to long COVID, sitting next to clinical trials, sitting next to nutritional needs. There is a vast well of resources that Umoja brings to the table, and not just in the form of a pamphlet, but in the commitment of their presence, because they go to the places that other people don't go. I hate to say it that way, but it is what it is. And so therefore, they are really taking on the issue of disparities, access, and improvement, and making it actionable through deliverable services. And they are helping us by leading the way to a large extent, and becoming a multiplying force, because we're in the community when we're with Umoja. And so that is one of the benefits that I really want to point out, because if you're a person that's unfortunately been diagnosed with cancer and you come to our table, you can pick up something for yourself, you can pick something for a relative that may have diabetes. There is where I feel like the families, the communities are really being taken care of. And with us working on cancer now, the reception is really warm, and it's growing, because practically everyone has been touched by cancer directly or indirectly. So there's a inherent understanding about cancer. And I think also what really makes this partnership special is because Public Health Commission and the Public Health Department are agencies and advisory boards that are directly responsible for engaging and speaking and really respecting community. The life experience of Dr. Rhodes, which if I would say for you all to, if you can, check out her Health Equity Requires Action presentation, in which she talks a bit about her life experience and members of her own family having cancer, and the issue of lack of access and treatment. And you can see the impact, because now that impact is actionable, because in the way in which the approach of Umoja is with community, the way in which there are educational components and progress around accessibility as a Black woman. And, you know, that really makes a difference, because oftentimes the barrier or some of the issues around process improvement is because there's really not a frame of reference around that plight. So you have to educate, present, then implement before you can get to the nexus of the problem. We didn't have that issue. because she shares that lived experience to an extent. And I think that what has come forth is more responsive, and we don't have the issue of earned mistrust as prevalent as we have had with other partners.
Z, thank you very much. That's actually a good segue to our next question, which is if you and Jane could both comment on challenges you've experienced in your work with academic partners, and not necessarily with Kim and Mara, but academic partners in general.
I will respond to that. Challenges with the academic partners. The agency is the trusted agency to serve the client. We know their needs. We work with them closely. But I would like to focus on our partnership with UCSF, just because it is a different partnership than we have with the school. The commitment that UCSF and Dr. and her team puts into this project, their commitment, the involvement, they're engaging, they work with the community, they not just with us, but they work with everyone. We meet every week. The distance, they're far away and we're here in Fresno. We meet every week to discuss challenges, best practices, what's going on with our project, any updates, and anything that just comes up, whether they're good or bad, we share those information. And some of those challenges we develop and become innovative, and some of the approaches and how to solve those issues. And a good example right now, because of the conservative Fresno County part of our module on the projects that we have, is the LGBTQ community. How do we address those? It's part of our curriculum. But when you go into a school and the school will say, no, you can't do that. You can't discuss those topics. So we address that with UCSF, and then we meet, and then so we become creative by, okay, if we can't talk about that module, then we can include that in some of the activities. And so the activities will have inclusivity languages and the topics that we discuss. So then even though they say no, but it's part of the activities, and so we address it that way, then we feel very successful, because even though that specific module was not introduced, it was part of the activity, and it becomes inclusive, especially with the LGBT community. It is very difficult. We are so behind. Fresno County is so behind on the policies that would help the LGBTQ. So sometimes it puts our agency in a difficult situation, and because it's part of the implementation, so working with the team, us able to create those innovative approaches, and that we're still successful because we can do that by just being creative, and that's from the brains of the UCSF team, and I think that's why we love this partnership.
So Z, I wonder if you could elaborate, and if you feel comfortable elaborating a little bit about earned mistrust.
Okay. Well, earned mistrust primarily has arisen and remains because the methods that oftentimes are brought to the community are extractive. They're there to get their little metrics, honey. They're not there for the mothers. They'll have more survey questions than conversations. Their presence isn't sustained. After they get what they need, they're gone. And the patients and the community is often left bereft of any benefit. Their usefulness has been met. That is an overwhelming feeling of communities, Black, brown, and poor communities. There's no presence established, and therefore there's no benefit that remains. And then a lot of times there's earned mistrust because there's no follow-up. A researcher may go in and want you to sign up for a trial, but they're not there for the tribulation. Meaning, if you're going to offer clinical trials, offer the support in case there's a diagnosis. And a lot of times that just wasn't happening. Everything was about a number. And So there was earned mistrust from, the way medicine and community disinvestment has happened historically, and oftentimes there are still remnants of it. So that's what I mean by earned mistrust, not hearing the patient, searching for the data, not listening to the patient, or the community helps to sustain that mistrust. And when they don't see themselves in the solution and they're only presented as a problem, then they remain a burden. And so that's how the mistrust remains.
Thank you, Z. And I think you used a very important word there, extractive. And so I would like to now turn the conversation over to Kim and Mara and ask you to talk about the steps that you take in your work with Sine, with Jane, and other community partners to prevent your work from being extractive.
So I guess I'll jump in.
Please.
So when I came back to UCSF in 2018, I had done similar work in the Cancer Center at Stanford, and I just said there were some things about the work and the language around the work and that kind of created some limitations in how we do the work. And so I had some time to think about that, and I really arrived at UCSF. That's where this idea of non-transactional comes from, because it really is saying we're not just here for this one study, and in fact we're here even when we don't have a study. And then there's a concept that was really bothering me, which was outreach. And it was this idea that that we have all the expertise, and so we're going to do some outreach because the people that we're outreaching to don't have any expertise or don't have resources. It's all like very deficit based. And so we sort of transitioned, and in our office in the Cancer Center and in the community, we always talk about reaching out, that there's an expectation that there's something to learn, right? Because if you're doing outreach, which by the way is a noun, which is also problematic for me as a surgeon, because I like to see some action, reaching out is action. And it anticipates that there is a bidirectionality. There's something that we are going to gain as an institution that's not simply just data, because if it's only data and then we leave, as Z described, then we've taken something. And so that led me to this concept of a kind of a give-take ratio. And I would recommend that as investigators, as you approach the community, try to think about like, what is your give? Because you're definitely going to be taking something if you're collecting data. So I started to think about like, is there a way to tip the balance so that there's more give than take? Because by definition, that is not extractive. But if we're not bringing anything to the table and then we're going to take data, you end up with a negative balance on the side of community. One key thing that I will say that we do and that we pay attention to in many of our community partnerships, we really didn't have to do it here because we were in Umoja, right? We were in it together. It was from the outset, was not something that UCSF was looking to get some data from the community and never give it back. So we gave the data, any data we collected during our various pop-ups, it came back to the community that same week. And then we asked, okay, what do we need to do? What do we need to do differently? How can we shift what we're doing? What was everybody's experience? Like, what are the things that we're missing? Where are our blind spots? And that's the magic of Umoja, is the unity allows for many blind spots to be covered because you're looking at things from so many different directions with different eyes. But the one concrete thing that I was going to mention is something that I learned community partner about how literally extractive we can be in our partnerships. Actually, two examples. One is when community partners have to hire a specific person to deal with all the requests that are coming from the academic institution. That means they're paying to be in collaboration with us. That is by definition extractive. And then the other thing that we've done, and we're actually trialing it right now, is that we co-hired a community staff. So they are embedded with our community partner, but we pay not only half of the salary, because we often will say, well, what's half of the salary? We don't ask about the benefits. So we pay half the salary and we pay all the benefits. And then the community partner only has to pay half the salary. They don't even have to cover the benefits. And so that there's a true exchange in that we then have sort of well-established trusted relationships kind of at the ready, because the staff is embedded with the partner, so they really work with the partner and their community collaborators. So we learn a lot, and then the community partner gets a staff who is not always working for UCSF, so we're also contributing to the capacity building of their organization. So I would say just really be conscientious about, like, what are you bringing to the table? And I want to caution that bringing new knowledge to the table or advancing the greater good, that's not bringing something to the table, because a lot of these communities are doing that already all the time for free.
Mara?
Just to build on that, we already are. Let me see how to say this. UC already has such expertise, right? We're just trying, with our collaborations, we're trying to elevate what they're already doing. They identify what they want to do. The community identifies what we do, and we just try to bring some resources. I think one of I always joke with my team, like, if I can just funnel money to places that need it, if I'm able to get some of those federal grants that maybe that by having the name recognition of UCSF, then that's not extractive. Just for an example, we started out, one of the federal fund grants was focusing more on adolescent sexual health, but the community kept saying, mental health, this is during COVID, this is a huge issue. So of course we listened, and of course we changed, we continued to do what we said we were going to do, but we added these other pieces that were responsive to the community. So 100% resources, making sure your money is actually reflective of the work that the community members are doing across the board, not just our official community partners, but if you're talking to somebody, what does that mean? Are you providing a gift certificate that's more than just, you can get what are the ones you sometimes see that, like, you can get entered to get something? No, just give them money. Transportation vouchers, food, all of those things, just obvious and so often neglected. I think also just the fact that we do co-develop all of our work together. So this is from developing the grant to developing the intervention to looking at the results to presenting the results back to the community and to the wider research institution. Building on what's already relevant to them, to the community, building on their strengths and interests, and where needed, helping to support that capacity building, if it is an additional training, if it is something else. And I think about some of the people that I've been working with at EOC who started out as a health educator. And some of them are maybe on this call right now, who are now, researchers at UCSF, who authentically know the community, and another health educator who's now running the whole project. So just seeing that continue with growth, seeing that EOC is now providing, is the provider of comprehensive sex ed for the county, for Fresno City, Fresno Unified, and things like that. I think that just demonstrates that building of what was already there.
Great. Thank you, Mara. I am going to go to the Q&A forum because we already have two great questions in the forum and would encourage other participants to type your questions. So I'm going to start with our first question and just read it out to you. So thank you for sharing about the powerful work of Emojicam. I have seen how folks in the Bayview have been loving its presence at the pop-up village. You mentioned long-term non-transactional partnership as important to your success. What other factors have contributed to how you've been able to dismantle the understanding that BIPOC aren't willing to engage in research or are unwilling to vaccinate?
Yeah, so I think my one word answer to that is humility. And I just think there's a way in which we call ourselves researchers versus community, when in reality we're all part of some community, and sometimes you're part of the community that you're working in, sometimes you're not. But the vulnerability of being community in contradistinction to sort of the power structure I think is true for all of us. And if we pay attention to the different places and the different contexts that we find ourselves in, we may not be the sort of at the top of the food chain and hierarchy. And I have always kind of carried that with me, and try to ensure that it gets operationalized. So right now I'm sitting at the Bayview Senior Center, where our team is vaccinating, checking blood pressures, doing diabetes screening. So once again, and colorectal cancer screening, which once again is non-transactional. It's not really my job to do all that. But you can see I'm wearing this t-shirt and I'm wearing a pair of jeans. And so when you come on site, you have no idea, like, who's your neighbor, who's a doctor, who's a medical assistant, who's giving the shots, who's checking you in. And it gets back to this kind of stone soup idea of like, everybody's got something. And our Baba Arnold Perkins, our chair of our community advisory board for the last 10 years and a founding member for the 18 or 19 years that we've been in existence, always says everyone is a piece of the puzzle and every piece is important. And it's just a matter of figuring out, like, what is the piece that people are bringing to the table, and seeing that as an asset that can be built on and that can, enhance, what we're trying to do. So I think the big theme is about humility and recognizing that we may have different kinds of expertise and resources, but none are more important than the other resources that are being brought to the table to achieve success. And just in that framework, that allows folks to have a relationship, and not just, and that's where the transactional piece comes. It's a relationship that goes both ways. And you saw, Z is embedded in a number of different things inside of our institution. So we're saying very explicitly that our institution is willing to be informed and influenced and change on the basis of that input. And so I think that real, acknowledgement and acceptance of bidirectionality requires a certain humility. It requires us to say, we don't know it all. We don't know how to do it right, right off the bat. And we need the input of the people who are living the lives that we're trying to impact in order to make sure that what we design kind of makes sense and is not sort of paternalistic. And so I would say that is like the whole nugget of why Umoja Health has been successful, why it continues to grow, even though I'm like, why is it still growing? Because people are attracted to the idea that they can be part of the solution. They're not being told that they are in line for a handout. Instead, they're like, okay, what are you bringing? What can you do? How can you use that and leverage it to move this equity agenda?
Thank you, Kim. Our next question is for Mara. First, Dr. Decker, thank you so much for bringing expertise and funding that makes a real impact on the Fresno community. I would like to hear about your process for choosing the Fresno community, engagement activities, and research before proposing a collaboration with EOC.
Great, what a good question. I think Jane alluded to the fact that we had known each other for that we had known EOC, we had known Jane and some of her other partners for several years beforehand. They are champions in the state, they're champions in the nation of improving access to quality care. So when there was a funding opportunity available, they were the first people I thought of. I knew that they already had the reach. I knew that they had the commitment. It was kind of an easy ask and an easy connection. That said, why Fresno? Fresno, as Jane mentioned, it's one of the fastest, maybe the fastest growing county in, well, the Central Valley, at least, in the state. So there's this huge growing population, and yet the services and resources have not kept up. There are lots of communities that are underserved. We work primarily in the rural communities, which are primarily recent immigrants, a lot of farm workers who don't have access to kind of your classic services. So knowing that Fresno EOC not only had the clinical expertise, but also had all these educational programs, had vocational training programs, had all of these other things, and had all these partnerships with Boys and Girls Clubs, with foster care, all of those kind of things made it an obvious choice. So the process, again, first we knew each other. We got to know and trust each other before we entered into something more concrete. And then after that, it was really thinking through, okay, whose roles, responsibilities, what do we want to do? How can we make this, beneficial? And I guess one other piece that I would just like to add is that concept of continuous quality improvement. Jane was very polite in alluding to some of the challenges she faced, but UCSF have problems all the time. We don't get whatever we need, and we'll chat with EOC. What can we do? How can we do a better job? It's really collaborative, and that concept of what can we do to improve ultimately the resources and services being offered and the health outcomes and reduce disparities. We're all in it for the same reason.
Great, thank you, Mara. Well, we have about 1 minute left. So if someone does have a burning, actually, we are at time right now. Just turned 1 o'clock. So I want to thank all of our participants. I want to thank Mara and Kim, and I especially want to thank Z and Jane for taking time to share your wisdom with us. And I hope that our participants, absorb that wisdom and take it forward as they work with communities to improve the health of those communities. So thank you very much, everyone.
Thank you.
Oh, and I'm supposed to remind everybody to do the survey. Thank you, Beth Thu. So please do the evaluation survey. Super important for our planning so that this series helps all of you at UCSF as much as we can in the work that you do. So thanks, everybody.